I'd like to introduce our next speaker, Mark Plummer, who'll be speaking about his company, Domillin.
Yep. Thank you for being here and giving me a chance to present to you about Domillin, where we're keeping the antibiotic miracle alive. I'd be remiss at this point if I didn't point out Liam Radcliffe's kind comments about investing in antibiotics about an hour and a half ago, right in this room. So let me do that. As you know, the business opportunity for antibiotics for last resort gram-negative infections is actually very, very good, with many of them being blockbusters. Currently, unfortunately, there are a high number of resistant infections in the United States, resulting in 25,000 deaths a year. This is about the same number of deaths that you hear about every day in the news that result from opioid overdoses, but you don't hear about the antibiotic resistant deaths. Globally, it's only going to accelerate. The WHO has estimated that it will cause 10 million deaths a year and $100 trillion in cumulative costs by 2050. The team that we have to lead this discovery effort is led by me. I'm the founder of Domillin. I work here at Yale. I formerly worked at Pfizer, where I worked on several cutting-edge gram-negative antibacterial projects. Our other team members are world leaders in antibacterial drug discovery and development, and they are Dave Nicolau, Brad Spellberg, and Robert Bonomo. Our invention begins with a novel core at the center in red. That's a non-beta-lactam penicillin binding protein inhibiting core. To the left of that is an address that specifically targets penicillin binding protein of gram-negative bacteria. And to the right is a rigid linker that's connected to a siderophore, which collectively reduce resistance to beta-lactamases and provide increased penetration into these gram-negative bacteria by about 100-fold. So for some results, this is against 2 priority 1 pathogens, MICs. This happens to be KPC, Klebsiella pneumonia, which has a 50% mortality rate in the US currently. These are clinical isolates, and you'll see there are 9 clinical isolates up there highlighted in red with KPCs. That means 4 or 5 of these patients died from their infection currently. The first column is the MICs of our first generation compound. You can see that the low numbers are quite good compared to ampicillin and penicillin, very high numbers, 3rd generation cephalosporin, ceftazidime, again high numbers. In the last resort, carbapenem, imipenem, we compare favorably to that. Everything in green, we're as good as imipenem or better than imipenem right now. Everybody wants to know, how are we doing against Pseudomonas and Acinetobacter? We do very, very well, very low numbers. It's great. We took one of those Pseudomonas and put it in a thigh infection model in a Hail Mary study before we had PK and protein binding, and what we saw is a dose-dependent reduction in CFUs after 3 doses. Others have found that with their experimental agents, it's taken up to 10 doses a day, 8 doses a day to treat the infection. So what I've shown you is 1 turn of the discovery synthesis cycle with testing in a thigh infection model. We believe that 5 or 6 turns of this cycle with an investment of $3 million will result in a potential lead clinical candidate. So what do we have? Why should you invest now? We have a new platform that works against WHO priority 1 pathogens. They're novel gram-negative antibacterial agents with high efficacy and initial indications of in vivo efficacy. And we have a very experienced team in place to drive discovery and development efforts. So keep the antibiotic miracle alive. We're the patients in need, your family, your children, and your grandchildren are all going to need these agents. Finally, I haven't been given the red flag yet, so let me speak about the picture here. This is an example of the first antibiotic miracle here in the United States. Ann Sheaf Miller was in New Haven. She was dying of a staph infection. 107-degree fever, a single dose of penicillin cured her in 1942. That's the antibiotic miracle that we're after. Thank you.
Excellent, Mark. Okay, questions?
Yes, sir.
Do you have any PK or any kind of stability data at this point on any of these leads?
I don't have PK on it. Stability is quite good. Meropenem in an IV bag decomposes about 10% in 2 hours. We dissolve our compound up in PBS at pH 7.4, and we decompose 10% in 2 weeks. So it's much, much more stable.
Other questions from the audience?
Yes, up here, I guess.
Is your compound active against Neisseria species?
I haven't tested it against that yet.
Time for one more. All right, great. Thanks so much, Mark.
Thank you.